بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بحضراتكم in case of the week 4 at our channel 4D Passion. This is a case referred to my center for second trimester anomaly scan with history of previous 3 babies, a stillbirth and another who died at 6 months of age, and a third who can't walk despite being at age of 3 years. The fetal growth was unremarkable, and was noted at scanning the fetal brain that there is bilateral choroid plexus cysts. One was septated and the other was echolocent. Also noted an abnormal morphology of the gallbladder concomitant with a Phrygian cap gallbladder. Here is a Phrygian cap in a case of adult ultrasound, and here is in our case. On further evaluating the orbits, you will notice that there is an echolocent pit noted here at the expected anatomical location of optic disc at fetal left eye. And here is a similar case from the web, a fetus at 30 weeks gestational age with a small pit concomitant with coloboma at orbit. Another case. And here is the expected normal anatomy of the orbit. It should be smoothly rounded at the site of retina and optic disc, and not pitted like here. Also, the fetal ear was at 5th percentile for gestational age. We have searched the OMIM site, online Mendelian inheritance. It's a site targeting collection of ultrasound findings and yielding possible syndromes. Usually on OMIM, when we put multiple findings, 3, 4, 5, it will give you a shorter list of possible syndromes, but usually there will be 4, 5, or even 6 or more syndromes, and this you can consider as a short list. However, when we search it, there is also a way to search on OMIM. You should put the rarest findings, then the most common and the most common. Surprisingly, when we searched the OMIM with the findings Phrygian cap gallbladder and coloboma and choroid plexus cyst, only one entry was achieved, that is CHARGE syndrome. And more surprisingly, when we searched OMIM by Phrygian cap gallbladder and the choroid plexus cyst, the same one entry, which is CHARGE syndrome, was also achieved. CHARGE syndrome is an autosomal dominant syndrome, and this could explain the bad obstetric history in this case. It has abnormal growth pattern. This can be postnatal, and anomalies of the head and neck, ears, eyes, nose, mouth, and the cardiovascular system. CHARGE syndrome has 6 letters. C for coloboma, usually retinochoroidal and cranial nerve defects that occur in 80 to 90% of cases. H for heart defects in 75 to 85% of cases, and A for atresia of the Kuani, which is present in 50 to 60% of cases, and R for retardation of growth, which is 70 to 80%, and developmental delay. G for genital underdevelopment due to hypogonadotrophic hypogonadism, and E for ear abnormalities and sensory neural hearing loss that is seen in more than 90% of cases. Symmetrical facial nerve palsy, cleft lip or palate, esophageal atresia, and or tracheoesophageal fistula can also occur. De novo or inherited with CHD gene variants 8q12.2. This is not detected for sure by using array CGH, and so molecular testing is recommended. And CHARGE syndrome is an autosomal dominant syndrome that have high risk for growth retardation and neurodevelopmental delay, with vision and hearing affection, with a high risk of 30% of mortality at first 5 years, and needs physical and social support. This could explain why 2 previous siblings of this case were dead at first 6 months of life. Its incidence is 1 to 12 per 100,000. The major criteria include ocular coloboma 80%, choanal atresia or stenosis 45%, cleft palate 25%, cranial nerve anomaly or dysfunction, and the ear anomaly. The minor criteria include genital hypoplasia, developmental delay, cardiovascular malformation, growth deficiency, orofacial cleft, tracheoesophageal fistula, distinctive facial features. Definite charge syndrome warrants 4 major characteristics or 3 major plus 3 minor characteristics. And possible or probable charge syndrome, like in our case, 1 or 2 major characteristics and several minor characteristics. The take-home message is whenever you find any anomaly, search carefully for other anomalies. Even subtle findings are supportive for diagnosis. Not every sonographic diagnosis will be definite, yet probable diagnosis will warrant further appropriate tests and help in genetic counseling. A very bad obstetric history, like in our case, should raise possible autosomal dominant syndrome. Deepest gratitude to Dr. Fazi Badruddin and Dr. Muhammad Ahmed Al-Masri, consultant ophthalmologists at Damanhur Ophthalmology Hospital, for their great participation in this work. And Assalamu alaikum wa rahmatullahi wa barakatuh. Kind regards and see you soon, Dr. Amr Farouk.